This is an educational symposium called New Concepts in Immunotherapy for Solid Tumors, Novel Immune Approaches, Biomarkers, and Combination Therapies. My name is Nair Rizvi. I'm from Columbia University. And joining me are Eddie Guerin from UCLA and Jeff Gibney from Lombardi Comprehensive Cancer Center and David Rim from Yale.
The following audio is based on a recent live webcast with Dr. Nair Rizvi, Dr. Jeffrey T. Gibney, Dr. Edward B. Guerin, and Dr. David L. Rim. This audio is part of a certified educational activity titled New Concepts in Immunotherapy for Solid Tumors, Novel Immune Approaches, Biomarkers, and Immune-Based Combinations. To access the entire activity and complete the post-test, please go online to www.peerviewpress.com/MWM. A printable monograph, slides, practice aids, and other features are also available.
So I'm going to just speak for the first few minutes around background information. As you know, the CTLA-4 checkpoint inhibitors were the first to hit the clinic with ipilimumab. The two main CTLA-4 antibodies are Ipi and Tremi. The PD-1 antibodies and PD-L1 antibodies are shown. The PD-1 antibodies in general are either IgG4 or IgG1 isotypes. In general, the PD-L1 antibodies that are IgG1 do require engineering to remove effector functions. So there's no ADCC, CDC that can lead to destruction of the T cells that you're trying to activate. Contrary to that premise is avelumab, which does have effector function. It is not engineered. It's a fully human IgG1. And interestingly, when we look at the activity with avelumab, it seems in the comparable range as the other PD-1, PD-L1 antibodies. So maybe that premise really isn't true. This clearly is a partial list. There are many companies developing PD-1, PD-L1, and CTLA-4 antibodies. So this is why we're all here. Bolded are areas where the FDA has approved immune checkpoint inhibitor therapies with either anti-PD-1, nivolumab, pembrolizumab, or PD-L1 antibodies. For lung cancer, which I mostly do, we now have 3 antibodies that are now approved for lung cancer, including nivolumab, pembrolizumab, and atezolizumab. The list just has to be updated almost on a weekly basis. Just within the last couple of weeks, avelumab was approved for Merkel cell carcinoma based on its high activity within that tumor type. There's activity really across multiple tumor types that you can see on the right. On the left, we still have some challenges around prostate cancer, microsatellite stable colon cancer. However, there's some encouraging activity combining PD-L1 antibodies with MEK inhibition, which Jeff will touch upon. But I think that some of the tumor types, such as pancreas cancer, which is a very dense tumor, not a lot of immune cells, I think continues to be a tough nut to crack. But I have to think that we'll be moving those tumor types on the left over to the right as we understand the biology better. And I think that the activity that we see in melanoma is really a foot in the door for every tumor type. We're really going to have a lot to cover because we're not focusing on one tumor type. We're really focusing on multiple tumor types where we have clinical information and looking at the data that led to many of the approvals of checkpoint inhibitors around melanoma, lung cancer, head and neck cancer, as well as others. A lot of experience now combining CTLA-4 and PD-1, but I think that again is and others just really step in the door, foot in the door, to give opportunity for new combinations and new targets, and we'll discuss that as well. One of the more befuddling aspects of immunotherapy is tumors and biomarkers. PD-L1 is used differently with lung cancer versus bladder cancer versus melanoma, and I think it makes it a little bit challenging. And then finally, I'll provide some sort of clinical perspective in terms of some of the issues that arise in the clinic and how we think about using these antibodies. And so Eddie's going to speak on foundational evidence on checkpoint blockade in cancer care. Thanks, Eddie.
Thank you very much, Nair. And in many respects, I have the easiest of the talks in that I'm not having to surmise a lot. I'm actually going through the data that led to the approval of all of these agents. And so, of course, the idea of cancer immunotherapy is not a particularly new one, but to be using it to the extent we are in our clinics clearly is quite new. So in the 80s, cytokines became used certainly early in my career in oncology. My big experience with immunotherapy was IL-2 for renal cell carcinoma, which was something that at our institution we did quite frequently. But what is generating, of course, the enthusiasm is really the checkpoint inhibitors, which have been really over the last 5 or so years something that has come to the forefront of oncology care. So for this audience, I certainly don't need to belabor this slide. As you can see, a T-cell response is going to occur with the T-cell receptor and the peptide on an MHC molecule. Then you will have either co-stimulatory or co-inhibitory molecules. And on the left, you'll see, of course, that response is seen when both of these occur. When only one occurs, a response is not seen. What we are looking at, and as an example for the PD-L1 antibodies or PD-1 antibodies, are instead of co-stimulatory molecules, really inhibitory molecules, and the idea being to use antibodies to prevent that second signal. So the foundation of these from a clinical perspective really is in the field of melanoma. So as you can see, ipilimumab led to a median overall survival that approached a year in patients with advanced melanoma. As you can see here, though, there is the big dot at 3 years, which shows that at that time the overall survival rate was 22%. That, in many respects, was more exciting than what was happening at the median. And what I think today we could say is even more exciting than that is even the longer-term data that shows that patients really are continuing to do well, that this is a true durable response. So melanoma, even with the success of ipilimumab, has of course seen many changes. This is a study in which the PD-1 antibody pembrolizumab was compared to ipilimumab. Here you see the data for overall survival. There was evaluation of 2 different schedules for pembrolizumab, every 2 weeks and every 3 weeks. They're so similar that at many points you can't even tell there are 2 lines there. However, they clearly do perform superiorly compared to the ipilimumab. And when one looks at progression-free survival, the results quite similar. One thing that, of course, has been an area of interest in melanoma is if you have 2 effective immune checkpoint inhibitors, can they be effectively combined in order to further improve response and further improve outcomes? And here you see data from Checkmate 067. This is looking at the PD-1 inhibitor nivolumab. And as you can see, in this instance, the progression-free survival of ipilimumab is shown at the bottom. The gray bar shows the progression-free survival for nivolumab, and the combination is shown on the top. Now, I think different people could look at this differently. I treat lung cancer rather than melanoma, and on one hand, clearly the line does appear to be higher. I think whether or not combination therapy and associated toxicity makes it important to give these concurrently versus sequential, I would leave to my colleagues in melanoma. So, of course, you're all aware that a very active area of research in immune checkpoint inhibitor therapy has been lung cancer, most specifically non-small cell lung cancer. As Nair pointed out, there are now 3 different approved agents for this nivolumab, pembrolizumab, and atezolizumab, and I will go through some of the data that led to those approvals. So the initial data was with nivolumab. This was was published back in June of 2012 by Suzanne Topolian and colleagues. And as you can see, the response rate overall was about 17%. Now, for many of you, this may not seem so good, but you have to remember this was previously treated non-small cell lung cancer. The comparator would have been docetaxel, at least that's what people would use, and that is approved based off of a 7% response rate. The encouraging thing in many respects is what you see over on the right. Scott Gettinger updated this data in the Journal of Clinical Oncology just a few years ago. At that point, it was a 3-year follow-up, and you can see that over a quarter of the patients, at least on what is the approved dose of nivolumab, continue to be alive at 3 years, very similar to the response rate, in fact. So nivolumab received then full approval based on 2 randomized studies. They looked at both squamous cell carcinoma in the CheckMate 017 study and non-squamous non-small cell lung cancer in the CheckMate 057 study. And you can see here in the overall survival figures, the blue nivolumab clearly outperformed docetaxel. One thing, however, that was interesting when one looks at the nivolumab versus docetaxel, particularly for non-squamous non-small cell lung cancer, which is the majority of what non-small cell lung cancer doctors see, is that there was actually these somewhat unusual progression-free survival curves. And what you can see is that the curves are, in fact, really crossing over. And for those of us who do lung cancer, this was very reminiscent of what was seen in data from Tony Mock in the IPASS study, in which patients who had demographic characteristics that made them likely to respond to an EGFR inhibitor were randomized to chemotherapy or an EGFR inhibitor. And at least in that study, the crossing over of the lines indicated 2 separate populations. In that case, EGFR mutant patients versus EGFR wild type patients. The question was, would there be a similar sort of grouping here? And at least the first suggestions were in a study that Nair and I were involved with, the Keynote 001 study. What you see here is actually the overall survival data, and the gray line is for patients who received pembrolizumab and had staining for PD-L1 in at least half of their cells. The Keynote 010 study was a confirmatory study, randomized phase 3 study, comparing pembrolizumab to docetaxel. 2 different doses of pembrolizumab were evaluated and compared to docetaxel, and as you can see, in all the patients who needed to be positive for PD-L1, there was an advantage in terms of overall survival, and that advantage was particularly marked amongst patients who had high-level staining in at least half of their cells. So, is this really 2 separate groups? I think that in some respects, the CheckMate 057 study, which again was the nivolumab versus docetaxel non-squamous non-small cell lung cancer, indicates perhaps there are. This was from a presentation by Luis Pazares, and what you can see here is that on top, at the 10% cut point for PD-L1 expression, that there was a clear advantage for nivolumab over docetaxel with a hazard ratio of 0.4. However, in the group of patients who had less than 10% staining, there really was no difference that was seen, and the hazard ratio there was 1.0. There, of course, is one additional checkpoint inhibitor that is approved in non-small cell lung cancer. Obviously, the combinations will be topics of later conversations here, but atezolizumab is approved. It is a PD-L1 inhibitor, and it is based off of data from Poplar, which was a phase 2 study comparing atezolizumab to docetaxel, and a very similar in design phase 3 study, the OAK study, that compared atezolizumab to docetaxel and showed a superiority of atezolizumab. One thing I will mention, which will come up again when we go through some of the GU data, they have looked at PD-L1 a little bit differently. They have looked not only at what happens in the tumor cell, but also at what happens in infiltrating immune cells. So in many respects, for I think the initial wave of PD-1 inhibitors, this ended up being sort of the most substantial thing to come out of it. One question was if you were able to identify a group of patients who derived particular benefit from a PD-1 inhibitor, could you then actually show that in that group it's better than frontline chemotherapy? In this, it differs. Non-small cell lung cancer differs somewhat from melanoma. Melanoma does not tend to have particularly effective chemotherapy regimens. Non-small cell lung cancer, our chemotherapy regimens, we don't think they're spectacular necessarily, but they do work. They do induce responses. They do extend progression-free survival and overall survival. And in this case, for the KEYNOTE-024 study, pembrolizumab in patients with staining for PD-L1 in at least half of their cells was compared to standard frontline chemotherapy. This showed an improvement in progression-free survival, which was the primary endpoint, but also even though crossover was allowed as part of this study, meaning that in patients who were randomized to chemotherapy, when things got worse, they were allowed to switch over to pembrolizumab. Still, there was a survival advantage for the pembrolizumab arm. Nivolumab, their frontline study, did not necessarily restrict patients to PD-L1 expression at this 50% cut point. They looked at a much lower cut point of 5%, and at least numerically, the progression-free survival in that study was in favor of chemotherapy. So, of course, the original checkpoint inhibitor approvals were in melanoma. Non-small cell lung cancer was in many respects next, but that is not the end of the story. As you can see here, this is something where you are looking at mutational load across different tumor types. You can see that melanoma is the most heavily mutated, followed by lung squamous carcinoma and lung adenocarcinoma. And in many respects, this is a figure not only of tumor mutational load, but the relative benefit with PD-1 or PD-L1 inhibitors. Now, I will say, of course, nothing in science is quite that easy. Some of you will note renal cell carcinoma, which I will mention, which is one of the approved indications for checkpoint inhibitors, is not all the way to the far side with melanoma and lung cancer. So one of these fairly heavily mutated cancers is head and neck cancer. So head and neck cancer is oftentimes strikes a similar patient population to non-small cell lung cancer. And in this study, pembrolizumab was given every 3 weeks to all patients. And as you can see, there was a mid-teens response rate for pembrolizumab. One thing that is important in head and neck cancer, there is a group of patients who has HPV as a causative factor of disease, where other patients have more typical mutagens, things like cigarette smoking and alcohol. And as you can see, there didn't appear to be a huge difference. This study was small, so differences based on PD-L1 are a little bit harder to interpret. The responses tended to be of good duration, similar to what has been seen in other malignancies. And as you can see in this waterfall plot, a majority of patients at least had some degree of tumor shrinkage when receiving pembrolizumab. And this led to FDA approval in head and neck cancer in 2016 for recurrent disease. We now have randomized data. This data looks at nivolumab as compared to investigators' choice of chemotherapy. And as you can see here, again, a survival advantage for the PD-1 inhibitor, in this case nivolumab, as compared to investigators' choice. And patients were more than twice as likely to be alive at a year if they were receiving nivolumab as compared to chemotherapy. This led as well to FDA approval in post-progression head and neck cancer. So another active area of study has been in GI and GU cancers, and this slide focuses particularly on GU. Renal cell carcinoma is a place where nivolumab is approved. Bladder cancer is another area that has led to approval of this class of drugs. Here you see data looking at atezolizumab in previously treated metastatic urothelial cancer. And here you can see the overall survival. As I had mentioned earlier, they have looked at staining for PD-L1 and immune infiltrating cells and felt that the survival was better amongst patients who had high staining in the immune infiltrating cells. So this slide is a single-arm experience looking at atezolizumab in previously untreated urothelial cancer patients who are ineligible for cisplatin. You will note that the x-axis of one is listed in years, whereas the other is listed in months. But you'll see that the response rate at least was impressive, and this was something that I think was considered to be certainly encouraging.
In April 2017, the FDA approved atezolizumab for the management of patients with previously untreated locally advanced or metastatic urothelial carcinoma who are not eligible for cisplatin-containing chemotherapy.
Nivolumab also has been evaluated in previously treated bladder cancer. In this case, looking at PD-L1 did appear to be associated with some difference in outcome, and this also is now approved by the US FDA. Pembrolizumab has a phase 3 study where it was compared to chemotherapy. Again, an improvement in overall survival as compared to chemotherapy, with patients being also more likely to be alive at a year if they were on the pembrolizumab arm. Again, an exploratory group looking at pembrolizumab in frontline therapy of advanced bladder cancer, showing a response rate of 24%. One thing that I will also point out is that although the efficacy comparison between gemcitabine cisplatin for bladder cancer and atezolizumab is that the toxicity profile of those two regimens is certainly something that is quite different and does need to be taken into account when thinking about this data. One of the early areas of evaluation for immune checkpoint inhibitors have been GI malignancies, and in those initial evaluations, colorectal cancer really was not a particularly effectively treated disease with immune checkpoint inhibitors. However, there's a small percentage of patients with colorectal cancer who do have this microsatellite instability, high phenotype based on deficiency of DNA mismatch repair genes. This actually was published in the New England Journal of Medicine. There are, of course, a couple ways one can get such a high-profile publication. One is by having a very large study, and the other is by having a very large effect. And this one was clearly the latter. You can see that the number of patients here is quite small, but that in this this microsatellite instability high group of patients, you can see that there was over 70% response rate. That being said, out of 7 patients, but still very impressive numbers as compared to a 0% response rate in those who did not have this mismatch repair deficient tumor. And that is on top of really a host of data that has looked at this as well. So the 0% seems quite real. The 71% could be a little bit high, but still is certainly exciting. You can see here progression-free survival curves, and as would be anticipated, the mutational burden was more than 20-fold higher in the MSI high group as compared to the others, and the progression-free survival, as you can see here, is quite different. Nivolumab also has been evaluated in this population, does lead to durable responses. This is a larger group, so maybe not quite as high numbers, but still very impressive results. One thing to point out is that colorectal cancer is not the only place that this phenotype is seen, but there are a whole host of malignancies where this is a potential area of future investigation. Here, I won't belabor this slide, just to say that there is a tremendous amount of research that continues to go on in the gastrointestinal malignancies, looking at how to bring checkpoint inhibition to that group of patients, many of those looking at combination-based approaches. I think this slide is interesting just because we actually now have a PD-1 inhibitor approved in Merkel cell carcinoma. This is not a particularly common tumor and is something that, for those of you who are in biotech or pharma, I think many groups are looking for any sort of tumor they could possibly find to show a signal and potentially have a drug approved. And in some ways, having an approval for Merkel cell carcinoma is indicative that even small tumor types can lead to approval for these class of agents. Here you can see a 31.8% response rate, and again, this did lead to the approval of the drug. Pembrolizumab also has data looking at Merkel cell carcinoma that also is quite favorable. So where does that leave us overall? We have many questions that remain. How does one evaluate how these patients are doing? When does one stop in a patient who's doing well? When does one stop in the therapy in a patient who's not doing well? And I think these are things that people have struggled with. This is a slide that looks at basically an unconventional response. Now, these are fairly uncommon in melanoma. I would say that they're just sort of a step above anecdotal in non-small cell lung cancer. And as far as other diseases, I don't know how common they are. But you can see here, this is a patient with 2 lesions. You can see that the one is shrinking sort of early on in therapy, but the other, this lesion in the area of the pancreas, actually initially grows and subsequently improves. For those clinicians in the room, certainly in what I do, which is non-small cell lung cancer, I would say that that most of the cases that look very unusual have already been presented or published, and that this is not, in fact, something that is sweeping our clinical care. But it is something to know if one does have an atypical response where some areas are getting better and some areas are getting worse, particularly in a patient who's feeling good. In terms of adverse events, in many respects, this class of drugs, when given as a single agent, that being PD-1 or PD-L1 inhibitors, are pretty well tolerated. However, our colleague Julie Bramer often gives a talk in which she explains that if it has an itis at the end of it, it can probably be induced by this class of drugs. And in many respects, that's true. You can see different immune-related adverse events really in essentially any organ. And this is something that is certainly a reason for caution and is a reason that we want people to be aware of the toxicities. This is what I will leave people with. The one thing that we want in terms of management is, although the management issues have not necessarily always been evaluated in placebo-controlled studies, it has been fairly consistent from one study to the next, that being that in people who have grade 1 toxicities, generally you're able to continue the drug, give symptomatic therapy for that problem. Grade 2, in general, we have tried to withhold the drug. Steroids can be given often in an outpatient setting. And in general, if there is improvement of those symptoms down to grade 1, and for those of you who don't conduct clinical trials, I know that it is very difficult, and sometimes the NCI does have a listing of all of these toxicities. Usually they are about what one would expect based on the grade that they're described as, but sometimes it can be a little confusing. But in general, once the toxicity has largely resolved, we have been willing to restart. In terms of grades 3 and 4 toxicities, we have discontinued the immunotherapy. We have, in general, tried to hospitalize the patients for IV therapy with steroids, and then have not gone back to the therapy. The one thing that I will say about that, and I'm sure for all of us in the group treating patients are starting to run into this problem, it is very easy when we're up at the podium to say that you would never start this patient back. But it's not so easy, particularly in someone who has done well, if things start to grow again, and they're in a situation where they're going to be dying of their stage 4 cancer, to be as firm as we are in a lecture. And I think that's something that we're all starting to struggle with as some of these patients are now having sort of their disease take over.
Yeah. Okay, Jeff's going to tell us about some combinations and where the future is for immunotherapy.
As a starting place, I thought this was a good slide. We're going to try to cover some of the new combination strategies with checkpoint therapy and other immune modulatory agents. It's near impossible to really cover them all, but looking at this from Chen et al. As sort of a roadmap, this is obviously adapted for this purpose, we can really try to harness the immune system at different points where there's immune recognition and cell killing. We are very familiar with the killing of the cells at the PD-1, PD-L1 tumor microenvironment, and we're also pretty familiar with priming and activation of T cells. This typically is in draining lymph node basins, such as anti-CTLA-4. But there's obviously a lot of steps on the way before you have an effective T cell response or immune response against a tumor. And these all represent areas that we can enhance or augment to improve the responses, or at least create a response in a patient with immune therapy. So the example that I think most of us in the room are very familiar with is anti-PD-1 plus anti-CTLA-4 therapy. Actually, I guess you could look at it as CTLA-4 then PD-1, because we're trying to prime maybe in the periphery and then enhance a response once it's in the tumor microenvironment. Ipilimumab, it's an anti-CTLA-4 monoclonal antibody that is interfering with the inhibitory signal or inactivation of T cells, allowing for better stimulation. There's also some other theories about it depleting Tregs and other ways that it may work, but it's enhancing a T cell response that allows cytokine release, proliferation, migration into the tumor. And then once we're in the tumor microenvironment, we have immune recognition of the tumor cell. We hopefully have successful engagement of it. Interferon gamma signaling may abrogate some of this, and you can have upregulation of checkpoints like PD-1. And this is where the second inhibitor comes in with PD-1 blockade and nivolumab, leading to hopefully a more effective strategy in treating patients. And if we look across studies for nivolumab plus ipilimumab, we have seen increased activity. Are we seeing synergism? We hope we are, but we're at least seeing additive effects, especially in melanoma. We know that with PD-1 drugs, we see responses around 40 to 45% in a treatment-naive advanced melanoma patient with an anti-PD-1 drug. Ipilimumab, somewhere around 10% up to 15%, depending which study you want to quote. And that gets us close to 60% in the phase 3 trial, Checkmate 067, that we just saw previously. And we see a pretty good response rate, and we also see some very deep responses that we think are very meaningful. Again, we're also seeing improvement, we think, in response rates in kidney cancer, non-small cell lung cancer. There are a number of randomized trials moving forward really to prove this, because these were in single-arm studies largely, or not with a true comparator arm. But we're hopefully moving the ball forward here with this combination strategy, at least in a number of different disease types. What we also have moved forward is the toxicity rates, and most of us are familiar with nivolumab plus ipilimumab, not only increasing objective response rate, but an equal increase in the grade 3-4 toxicity rate to where about half the patients experience something pretty significant. And this tends to be largely in the GI tract, the colitis, in hepatic or hepatitis, discontinuation rate 40%. And this is real. We do see it in the clinic. But patients get through it. The side effects we think are typically manageable, or at least in our clinics, we can manage them very successfully, even though they are more frequent. Now, modification of the dose has been a theme that we've seen when we've moved from melanoma to lung cancer, which is the 012 study. The schedule was changed, so rather than giving full dose IPI, a lower dose of Nivo as an induction phase 4 times. It's now been spread out where you give a low dose of IPI, IPI-1, and you give it every 6 or 12 weeks, and you just continue with the nivolumab. And we see that the grade 3-4 toxicity rate was lower. More patients were able to stay on drug or at a lower rate of discontinuation due to AE. And moving forward, we may see that the regimens or the dosing schedules shift. And what I don't show here in the 012, well, actually, I guess it's over here, is that the response rates looked pretty good when you had a modified dosing schedule for the ipilimumab. So that we're pretty familiar with, but what about the newer targets? These are not all checkpoints. IDO, I guess you could call it somewhere in between. IDO1 is present in a number of cells, the tumor cells, dendritic cells, macrophages, B lymphocytes, and as well as other cell populations. And it's an enzyme. It's catabolizing tryptophan to kynurenine, and that doesn't seem to be too important, but until you realize that whether you have tryptophan depletion or kynurenine that's accumulating, that actually can dampen immune response. And depending on which cell you're looking at, this can have different effects, but this ultimately can lead to tolerance and tumor cell evasion. So it's a very exciting target for immunotherapy and trying to elicit anti-tumor responses. We've now seen IDO inhibitors, and this is a peptide trying to deplete cells that have IDO expression, move forward from phase 1 and even to phase 3 with epacadostat. These generally have been relatively well tolerated, no major toxicity concerns up front, but unfortunately, there was not a lot of activity. Stable disease was generally seen as the best response in the monotherapy setting. I think the one exception, if you were to look up this study with IDO5 peptide, this was in a lot of mainly lung cancer patients, there was potentially some additional benefit. But this has now moved forward in combination, so combining IDO inhibitors with not just immune checkpoint therapy, vaccine, chemotherapy, potentially others. And there's a lot of preclinical data that's emerging where it suggests this is a very effective strategy. And I'm going to move on to one study that came out, Dr. Spranger and Gajewski's lab over at University of Chicago, looking at combination checkpoint therapy, both anti-CTLA-4 and the anti-PD-L1 agent in combination with IDO1 inhibition. And this is in a B16 mouse melanoma model. And as you can see here, this yellow curve is the combination where the disease burden was very well controlled when it was given combination, and it was superior compared to PD-L1 alone, anti-CTLA-4 alone, the IDO alone, or the control experiments. So we think that in this preclinical model, there's a suggestion of synergism between the combination with checkpoint therapy. Both of these have now moved forward into clinical trials. The anti-CTLA-4 therapy I was involved with when I was at Moffitt before I moved to Georgetown. We presented that data at ASCO a few years back, and it was very interesting, potentially increased activity in patients. And we're going to look at the epacadostat plus pembrolizumab data that has been now presented at a few meetings, including at SITC and ESMO. This was a phase 1/2 study in patients with a range of tumor types, given a standard dose of pembrolizumab, 2 milligrams per kilogram, and escalating dose of epacadostat. This is an oral agent given continuously, 25 milligrams BID up to 300 milligrams BID. This led to dose expansion phase and did lead to a randomized phase 2 dose, which is 300, and is now being explored in a number of tumor types. So the data that came out of this was very exciting, although we have to dampen it because the sample size was not very large. That in the melanoma cohort, especially in treatment-naive patients, the objective response rate was 58%. So this is basically rivaling numbers that we've seen with nivolumab plus ipilimumab. And we saw a 26% complete response rate. Again, that's only a few patients, but we never saw a 26% response rate with any other IO therapy that we've been studying. Also in the non-small cell lung cancer cohort, 42% objective response rate. So the early signs of potentially enhanced activity, which I think is very exciting for a lot of us in the IO space. Looking at melanoma, you can see in this waterfall plot clearly some very good complete responders. These were PD-L1 positive tumors. We have a few great responders, though, in this case that were either PD-L1 unknown, these blue, or they actually were negative to PRs in the melanoma cohort. Non-small cell lung cancer in terms of the PD-L1 status and renal cell, less data, but again, there's one patient, non-small cell lung cancer, that was PD-L1 negative that had a partial response, 2 unknown. So this might actually expand the number of responders to a PD-1 or PD-L1 based therapy that are not expressing PD-L1 on the tumor's surface. The other interesting point of this study is that the tolerability was fairly good. That if you look at the grade 3/4 toxicity rate, it was only 19%. For a combination strategy, that's very exciting. The two areas that we saw a fairly high increase in the toxicities for grade 3/4 rates were rash, which most of us feel very comfortable managing in the clinics. And then lipase amylase were increased. This is a phenomenon that we now see. Most of the time it's asymptomatic patients, as long as it's not grade 4. A lot of times these patients still get treated. And the treatment-related adverse events that led to discontinuation, only 8% of patients. And overall, this was a well-tolerated therapy that's now moved forward. And the study that's leading the pack, ECHO 301, pembrolizumab plus epacadostat in unresectable or metastatic melanoma, randomized trial getting pembrolizumab plus epacadostat versus pembrolizumab and placebo. This is accruing patients. It won't be for a while before we see results, but very exciting. Now, epacadostat is not the only IDO inhibitor. Indoximab is another one that's been studied. This is a phase 2 trial that had a very interesting design. Patients actually go from one checkpoint to the other and stay on the IDO1 inhibitor. The tolerability appeared fairly well. There was no concern over a safety signal. And the response rate, when they grouped all the data together, 36%. This includes patients that were ipilimumab plus indoximab, as well as anti-PD-1 plus indoximab. And the majority of them actually were getting pembrolizumab. And in that case, they saw a comparable response rate, 53%, to what we saw in the epacadostat study. Now, the follow-up for this study was relatively short when it was presented at ASCO. You can see one person that was actually followed out a little bit longer. You also have some patients having what would have been captured probably as stable disease. So another interesting combination with IDO inhibitors. But there's also a few other studies ongoing that are worth mentioning. So epacadostat being combined with other checkpoint therapy, nivolumab. Epacadostat being combined with atezolizumab, primarily non-small cell lung cancer, another anti-PD-L1, durvalumab, and GDC0919 is another IDO1 inhibitor combined with atezolizumab. So this may emerge as a very exciting new combination strategy where we have multiple regimens in different tumor types. So, where do we go from here? Just looking at a list of trials that were presented at ASCO, very exciting data from a number of them. Obviously, we can't cover them all, but talking about the first one with pembrolizumab plus 4-1BB agonist. So this is a co-stimulatory signal on the T cells. Otilimumab, I think I got that right, in phase 1B plus pembrolizumab. So this is a IgG2 agonist monoclonal antibody that binds to 4-1BB. It's stimulating T cell response. If you recall in that very first slide I showed, this could be in the priming activation phase, but it actually could be really anywhere in that roadmap for immunotherapy. And in preclinical models, it has been shown to amplify or increase anti-tumor responses. And the first data that was presented on this at ASCO looked fairly promising. The toxicity profiles, there was nothing too alarming in that data, and there were some interesting responders. So if you count up these number of bars, it's not an exceptionally high response rate, so 6 objective responses out of 23 patients. But if you look at who these patients were or are, I think that's where it's a little bit more interesting. So you can see the blue here is a small cell lung cancer patient. I guess this is teal, renal cell carcinoma, and then there was an anaplastic thyroid carcinoma patient in this green that had a very deep partial response. So are we seeing synergism, enhanced effect, or are they just lucky that it was a PD-1 response? We don't know, but it's at least very promising. Another strategy, this is slightly different, looking at an agent, Leary, that's targeting more the natural killer cells. We know that nivolumab does improve survival. There's a reasonably good objective response rate of nivolumab in the second-line area for squamous cell head and neck cancer. You can see here in the phase 3 trial was 13.3%. Combining the Leary with nivolumab, there's preclinical data showing this makes sense, partly because NK cell population infiltration is associated in these tumor types, and that the combination may enhance the anti-tumor effect. In this study, it reports the activity rate at 24%, so a bit better than what we saw from the phase 3 trial. Complete response rate of 3 patients, but this was 10%. So this early data suggests that we may be seeing enhanced activity with the combination with an anti-KIR monoclonal antibody nivolumab, at least in head and neck cancer. So transitioning to a slightly different approach with immunotherapy, this is Tvex. So I think a lot of people in the room are very familiar with this, but if you're not, this is a modified oncolytic virus. So it's a herpes virus that's been attenuated a bit, also has a gene with GM-CSF inserted in it, and it's a direct intralesional therapy for melanoma primarily that's been developed, but it certainly is interesting as a development in other tumor types. And it may turn what we call a non-inflamed cold tumor. There's not a lot of inflammation going on into an inflamed hot tumor where you inject the tumor with the virus, it infects the cells, it causes local destruction, affects the nearby cells, it secretes GM-CSF, and it draws in an immune response. And you can see in this example of a patient with dermal metastases with melanoma, each one of these were injected, and at week 18, there's a complete response. This has now been combined with ipilimumab, 50% objective response rate in the phase 1 study. Do have to keep in mind that a lot of these patients have less advanced disease than some of the other studies that we're talking about, but still very impressive. And you can see in this waterfall plot that there's patients with stage 3 disease all the way to M1b stage 4 disease for melanoma, the most close to the most advanced. This would be the most advanced that had complete responses. Now, there's also data with Tvex plus anti-PD-1 therapy. The preliminary data was presented at SMR, and 57% of patients had an objective response in that study. This has led to a randomized phase 3 study design in advanced melanoma patients. Must be treatment naive except for a BRAF inhibitor, and they must have injectable lesions. So it does select out a patient population that may differ from the other trials. And it's going to be a randomized trial where you get Tvex plus Pemble versus pembrolizumab alone. There is a placebo control to it. So the other area that I want to touch on, because this has been evolving, I think, very quickly, and it does make a lot of sense that we may be able to combine targeted therapy with some of our immune checkpoint therapies. Some of the initial attempts didn't go very well. I don't know if you guys remember ipilimumab combined with vemurafenib. That was stopped early. There was a New England Journal letter. The data was never really fully reported, but there was toxicity that was unacceptable and really stopped in its tracks. Ipilimumab plus dabrafenib plus and trametinib, BRAF MEK drugs, and BRAF mutant melanoma, that was also stopped early. There were colitis issues with that. But we hope that with PD-1 drugs, it'll be more successful combining with targeted therapy. And there's strong rationale for using a targeted therapy to enhance immune response with anti-PD-1. And these are just 3 examples: enhanced tumor antigen release, expression on the tumor cell surface, modulation of immune checkpoints may actually bring down PD-L1 on a tumor cell, and it also can suppress cytokines that may be secreted in the tumor microenvironment. And you may also enhance the T cell activity. So think about BRAF inhibitors. They inhibit mutant BRAF, but they actually may stimulate the MAP kinase pathway in BRAF wild-type cells, which is pretty much every other cell in the body. So you may actually enhance T cell activity. And if you look at melanoma, and these are tumor samples from patients treated with a BRAF inhibitor at baseline, pre-treatment, and post, you can see a dense infiltrate of CD8 positive T cells that was seen after treatment. This tends to be a time-dependent effect that early on you see the infiltration, down the road you may actually lose that in that progression, but it's a very statistically significant influx of T cells, especially the cytotoxic CD8 positive T cells that you see with BRAF therapy in advanced melanoma. And it's not only that, you can see changes that are very favorable for an immune strategy, where you see a decrease in some of the immune suppressive cytokines with BRAF targeted therapy, including IL-6 and IL-8. You also see an increase in the cytotoxic activity of the T cells, so that would be porphyrin and granzyme B. However, you do see some mechanisms that are occurring that may dampen an immune response, and that's with TIM3, so this is PD-1. These obviously can dampen or inhibit immune responses. And then the one that we're obviously all very familiar with is PD-L1 expression. That PD-L1 expression can go up in the tumor microenvironment when it's exposed to a BRAF targeted therapy. So that may mitigate some of the immune effect in eradicating a tumor that's already responded to a upfront treatment with BRAF therapy. So we now have trials that are moving forward, or we have at least early data with PD-1, PD-L1 therapies combined with targeted therapy in melanoma. This study with atezolizumab and cobimetinib, a MEK inhibitor, this was presented at SMR this past year. And there was actually, I believe, 21 patients, but 20 with non-ocular melanoma, and half of them were BRAF mutant. They were allowed to have prior treatment an objective response rate of 45% across the board, 50% response rate in the BRAF wild-type patients. So it's potentially enhanced activity, although it's very hard to tease that out from this study. The grade 3/4 adverse event rate did go up, which is not too surprising, given that both of these agents can lead to an additive effect close to this number. Some of the AEs that were notable were diarrhea and rash. At the presentation, it was thought that this was maybe not the best tolerated, but acceptable to move forward, this was not prohibiting further study. And this has now moved forward with atezolizumab plus vemurafenib and cobimetinib, phase 1b. 29 patients, BRAF mutant melanoma, that were treated. There is a run-in period, the way they've evolved, where vemurafenib and cobimetinib, the MEK inhibitor, are given for a 28-day window before the anti-PD-L1 agent's given, and then actually the vemurafenib is given at a slightly lower dose, rather than 960 milligrams twice a day, it's 720. And then in this study, a higher overall objective response rate, 83%, was seen. So this is very promising that we're actually getting numbers that may do a whole lot better than just the single strategies alone. Complete response rate 10%. A grade 3/4 adverse event rate of 40% is acceptable, although we do see some fairly significant AEs in some patients in this study, including hepatitis picture, this myositis, sepsis in one patient, and diarrhea. Where are we going forward? It's not just anti-PD-L1, but also anti-PD-1. And the KEYNOTE-002 is a very similar concept, pembrolizumab plus dabrafenib and trametinib. And this data was presented at ASCO by Tony Ribas. Still very early data. 15 patients, no prior BRAF or MEK therapy. There was no run-in period, so everyone got all three agents, standard dosing from the very beginning. An objective response rate of 60%, a little higher grade 3/4 adverse event rate was reported. Again, the liver was an area that was of concern. Neutropenia was observed in a patient that was dose-limiting toxicity, and 33% of all patients discontinued treatment due to adverse events, so a little higher than what we see for pembrolizumab alone. But still very promising. Both of these strategies are now moving forward in randomized trials. So the phase 3 trial of atezolizumab and cobimetinib in metastatic melanoma. This is a randomized trial, phase 3, 500 patients. The PD-L1 will be the placebo. So all patients will be BRAF targeted therapy, and half the patients will be getting atezolizumab on top of that. KEYNOTE-002 actually was a phase 1b to phase 2 trial, and this is the expansion into phase 2, randomized design, 1-to-1, primary endpoint PFS, and these are in patients that are treatment naive, BRAF mutant melanoma. Again, everyone's getting BRAF targeted therapy, dabrafenib plus trametinib, and half the patients are getting anti-PD-1 therapy with pembrolizumab. So it's not just a melanoma story, we're also seeing potentially combined enhanced effects with anti-PD-L1 and targeted therapy in renal cell carcinoma. And I think the preclinical data looks kind of interesting. In this study, it came out of MD Anderson, in patients' primary tumors that were removed after sunitinib or bevacizumab, these are anti-VEGF or VEGFR therapies, they did see a higher density of CD8 positive T cells, they saw a higher density of Tregs, and they also saw a higher positivity rate for PD-L1. And interestingly, these tumors that had higher PD-L1, higher T cell infiltrate, actually those patients did worse. That it's a little bit different than what we've seen from other biomarker studies, that you can see the overall survival in the patients that were in the blue, the sunitinib was less. Same thing with bevacizumab, PFS, and OS. It may be a little harder to interpret, but this actually overlaps with the data that was presented from the COMPARES trial, patients with renal cell carcinoma getting pazopanib or sunitinib, and these are baseline tumors where they showed that if you were high for PD-L1 in this trial, so this would be the orange line and the light blue line, you actually had a worse overall survival. And if you look at the breakdown for median, it's very obvious who were the patients that did better, and these were the sunitinib patients that had low PD-L1, pazopanib patients that had low PD-L1 compared to the patients that had high PD-L staining. So it does suggest that maybe we should be combining with anti-PD-1 or PD-L1 therapy. And in the study of axitinib plus pembro, advanced renal cell carcinoma, this was presented at ESMO, an objective response rate of 70% was seen, which is, I think, very exciting. Both agents have response rates, ballpark, say 25%, so even more than an additive effect. Although they warn that this is very early data, in fact, PFS data was too immature to represent, but still very exciting. And you can see here the depth of the responses. Majority of patients had tumor shrinkage. The other part is that the toxicity profile, this is grade 3 or above any event, that 65% did have an event. But if you count it as immune-related, it was far less, 19%. This is always very tricky to interpret in studies that we've been doing. But it does suggest that when you go from treatment-emergent to immune-related, these are the ones that are more related to the drugs themselves. Again, you see liver toxicity, diarrhea as well. These strategies are now moving forward. There are 3 randomized studies that are looking at VEGF, VEGFR therapy in combination with a PD-1 or PD-L1 agent, and pembrolizumab plus axitinib versus sunitinib monotherapy. In Javelin 101, we have avelumab plus axitinib and sunitinib. And then in this last one, Keynote 18, is with pazopanib. And we did see some data with Checkmate 016 I just wanted to bring up where there was activity, but also the adverse event rate was similarly high in that study. So I know this was a very quick whirlwind through a number of combination strategies. Where are we going from here? It's hopefully that we're not just going to combine every drug we possibly can and then throw it at a patient, that we need to be smarter about. It needs to be based on a patient's characteristics, a tumor's characteristic, or some type of composite biomarker strategy. And this is a very big oversimplification of the problem ahead of us, but talking about things as inflamed versus non-inflamed, there are different strategies where you may be able to enhance immune response based on PD-L1 expression. Are there immune targets otherwise? Do you have problems with antigen expression that you have to try to overcome? For example, is MHC loss? You're not going to actually have great T-cell responses. You have to approach a different way. So this is a reference that might be worth reading by Kim et al. And certainly I think a lot of us at the table here are very interested in this topic. So with that, that's my last slide, and I will hand it over to Mayor. Thank you.
So I think that combinations are very challenging for IO. When we give chemotherapy, it's A plus B and equals C in terms of efficacy, whereas with IDO inhibitors or MEK inhibitors, there may not be any single agent activity, but the combinations are really compelling. The best example that I know of that is the small data set with atezolizumab and cobimetinib in MSI stable colorectal cancer. So these are not MSI high tumors, these are MSI stable colorectal cancer where the response rate with IO is 0, the response rate with MEK inhibition is probably 0, yet the combination in 20 patients with KRAS mutant colorectal cancer, the response rate was 20%. So we have a lot to understand around the combinations. Next, Jeff's last slide, looking at the paradigm of inflamed versus non-inflamed, trying to parse out subgroups that we can identify with different genetic and immune phenotypes to create immunotailored therapy is a great segue to David, who really has dedicated his efforts recently around immunotherapy biomarkers. Thanks, Dave.
So actually what I want to talk to you about today is what's so exciting about immune therapy is actually the fact that most likely, more than any therapy in the past, this is one that's truly going to be a companion diagnostic therapy or precision medicine or personalized medicine therapy, and that's what it's going to take to figure out which patients respond. And as you saw in all the previous all the previous speakers, you could see that there was clearly lots of different classifications of disease and lots of different responses. And so it's the pathologist that's charged with being able to tell which is which and then pass on to our oncology colleagues which patients fall in which classes and then how we can determine which drugs or combinations they should get. And so I'm going to go through a few different topics today. First, we're going to talk about an update on the current FDA-approved companion diagnostic, PD-L1, and I'll tell you about the difference between that and a complementary diagnostic test, which is actually true as well, also FDA-approved. Then we'll talk about some novel biomarkers. First, I'll talk about genetic biomarkers, that is mutational load, which was really first brought to our attention by our chair today, Dr. Rizvi. And then we'll talk about the future biomarker landscape, including some new approaches to thinking about the biomarkers that might allow us to look in a more personalized way at therapies, specifically the T-cell activation panel, capacity to express PD-L1, and finally an 18-gene nanostring RNA expression signature. Dr. Garon and Dr. Gibney went through a bunch of these papers, so I'm not going to spend a lot of time going through them, but the salient feature of these was no matter which paper you looked at, the PD-L1 high patients always did better than the PD-L1 or showed greater response than the PD-L1 low. So as much as we don't like this particular companion diagnostic test, it really has signal. And then even when we got to combinations, in the more recent work combining Nivo and Ipi, we still see the same thing. That is, the higher the levels of PD-L1, the greater the response rate. So I think that at least in the beginning, we're definitely going to be using PD-L1 as a companion diagnostic test. And so what I'd like to do to start with is go through the different drugs and what their companion diagnostic or complementary diagnostic tests are and what the differences are and why. And so these are the four main drugs that have been seen in this space. We heard a little bit about Merkel cell, which adds a fifth. But what you can see is that each of these drugs has a different test or assay, which is positively distressing for pathologists and led to an FDA and AACR convened meeting to talk about this problem because in the pathology world, we usually test for a single biomarker with any number of tests which might correspond to any number of drugs. But here we see that each test is associated with a different drug. And not only is it different, but each one is based on a different antibody and uses a different scoring system. So how do we deal with this problem? So where we are today is that we have only one FDA-approved test, and that's 22C3. This is FDA-approved as a companion diagnostic for pembrolizumab in the first line. That is, if there's greater than 50% cells expressing, but in the second line, if it's greater than 1%. The rest of the tests are all complementary diagnostic tests. That means it's useful and it could be helpful, but it's not required in order to prescribe the drug. So that's an important distinction because as pathologists, we may or may not decide to do that test depending on situations other than the drug, the response to therapy. That is, market forces and other things play a role. A lot of times we won't do a complementary diagnostic test because we don't have to do it. And similarly, oncologists don't necessarily need to use it. It's helpful, but not necessary. So nivolumab is the first example that does not require a companion diagnostic test, but rather a complementary diagnostic test. And the 28/8 assay, which is FDA approved as a complementary diagnostic test, uses a very low cut point, greater than 1% tumor cells positive. The SP142 test is also FDA approved, and that's a complementary diagnostic test for atezolizumab. It's in bladder cancer and more recently in lung cancer as well. And not only that, as I'll show you in a second, you read it differently. You read the immune cells as opposed to the tumor cells and give it a scoring system. Another test, SP263, has not yet been approved as a companion diagnostic test, but we'll probably see it as either a companion or a complementary later on this year when durvalumab is evaluated by the FDA. And finally, there's an antibody and a test called a lab-derived test that's been used, which is neither a complementary or a companion diagnostic test, but it's a test pathologists invent in their own labs, so to speak, or at least validate in their own labs. And this has actually been used in a number of places, most significantly Memorial Sloan Kettering and Brigham and Women's Hospital use this as their standard test, on which they test most lung cancer and some melanoma patients. The first question we want to talk about is, are these all the same? So there's now 3 publications describing these 3 tests that are comparative. This so-called blueprint project was the result of the FDA AACR ASCO meeting, and it was led by Fred Hirsch, but included a number of people from each of the companies, including each of the diagnostic companies. In contrast, our study that was led by Ignacio Westuba and I was sponsored by the NCCN, although paid for by BMS, and this was supposed to be a statistically powered prospective multi-institutional test without including any of the producers of either the drugs or the companion diagnostic tests. And finally, there's a last paper that came out that's got the most patients in it, so I'll show you that as well. So here's a comparison of the tests. The blueprint test had 39 cases, read by 3 pathologists, 1 from DACO and 2 from Ventana, and looked at 4 assays that are FDA cleared as either complementary or companion tests. It was not statistically powered, but it was a tour de force to get these 6 companies to agree on the study and then to agree on publication. The NCCN study was 90 cases. It was done by 13 pathologists from 7 different academic sites, included 4 assays, but excluded the SP263 assay, since at the time it was not, still is not FDA approved, and instead used a lab-derived test, which was E1L3N, a cell signaling antibody on the Lycobond platform. It was statistically powered for interclass correlation coefficient between pathologists, between assays, and by subcellular localization. So we asked 3 questions instead of 1 in this study, and this was led by the NCCN. And you can see the difference right away here by looking at the assay and then the scores. And you can see 3 of the assays in both studies look fairly similar, although there was 1 outlier assay in the light green here and in the light aqua here. And you can see that particular assay, the SP142 assay, recognizes fewer patients. This is what they actually look like when you look down the microscope tubes, and you could see that while these assays look similar, the different amplification systems gave them some different coloration, but this one looks like it's missing cells. That is, there's a lot of cells that are positive here that are negative in the serial section. This is what they saw in the blueprint. This is what we saw in the NCCN study. However, we're informed by the vendor, by Ventana, that this assay is designed to detect immune cells. So what does that mean? How does an antibody know whether an antigen is in an immune cell or a tumor cell? I have trouble with that. Now, I know that they showed this as an example where you can see more immune cells here in the center compared to the tumor cells on the outside, but I'm not sure that wasn't just actually an optical illusion, since it seems like there's fewer tumor cells, not more immune cells in this particular assay. So we looked at that in both studies as well, and in the blueprint study, where there was only 39 patients, or 39 specimens looked at, you couldn't see the difference between any of the assays when reading immune cells. However, in the NCCN study, where we had statistical power, you could see that the immune cells were actually lower than the other 3 tests as well. And so this was the best evidence that we have that even the immune cells were also detected at a lower level than the tumor cells. Now, the way that they looked at this is different between the different studies, and specifically, concordance was hard to measure because each assay came with a different set of cut points. And so what they did in the blueprint study is they used the cut point for each assay and just called it positive, negative, and asked what their concordance was. And unfortunately, it wasn't very good. It was only about 63% concordant between the assays, which means you clearly couldn't cross-utilize assays between drugs with only a 64% concordance. And the ones that were concordant are the really high expressors and the really low expressors, and the ones in the middle were the ones that were non-concordant. We could look at this in another way in the NCCN study. We used every scoring category that was possible, which left us with 6 scoring categories, which you can see here. And you can also see something interesting in the distribution of the scoring categories for each of these assays. You can see what looks almost like a bimodal distribution, except for SP142, where there aren't as many positive cases. And in fact, in SP142, over 50% fewer patients are considered positive by that assay when you're looking at tumor cell scoring. The others were actually quite similar at either the higher cut point, greater than 50%, or the lower cut point, greater than 1%. The immune cell distribution is similar in that the SP142 was about half what was seen in the other 3 assays, where the other 3 assays were approximately equivalent. The NCCN study, because it was done by 13 pathologists, gave us the opportunity to statistically test the levels of expression, which we couldn't do in the real-world setting. In the real world, one pathologist reads your slide and that's it. But in this experimental setting, we could average the readings of 13 different pathologists, and then we could actually see a subtle difference that couldn't be seen in previous studies, and that was that actually the 22C3 assay is slightly, in fact, statistically significantly lower than the other two assays. In fact, the only two that are not statistically significantly different are the LDT E1L3N and the 28-8 assay. The 22C3 is slightly lower, a factor of 0.3. The SP142 is dramatically lower, 1.2 order of magnitude of the difference of the mean. And so you could see that the average pathologist score could allow us to look at statistical significance. The other thing you can do is look at interclass correlation coefficient. This is what your level of agreement is for the assays. And here you can see for each of the assays, whether for the tumor, there's a very high agreement. And 0.97 is ridiculously good agreement, assay read by pathologists. This is, again, the averages, so that we're looking at the differences of the assays, not the differences of the pathologists. However, for the immune cell, when you looked at all four assays, it was pretty bad. Anything below 0.4 is really unacceptable for clinical use. And you can see that one's 0.27. Now, we eliminated SP142. We actually did have a reasonable concordance for immune cell staining. Now, the next variable we want to look at is the pathologist, because the pathologist could also be a reason why there's variability in this assay. And in fact, this is really interesting, because if you look at the interclass correlation coefficient for the pathologist, regardless of which assay you use, if you're reading tumor cells, we do great. Pathologists can do this assay. We all have a concordance or ICCs above 0.8, which is really good. But the bad news is, and what's something that is a concern to me, is that for the immune cells, we are discordant regardless of which assay we use. And so that means, even though you heard our previous oncology speakers talk about using immune cells in bladder cancer and in head and neck cancer and certainly in lung cancer for one of the drugs, pathologists probably shouldn't read that assay. At least according to this study, pathologists can't agree on the level of immune cells with ICCs all below 0.2. Now, when we look at tumor cells, we can look at two different variables and see how well we can read tumor cells as long as we're comparing pathologists. And what you can see is that when we have a cutoff of greater than 50%, we got this. Pathologists are really good at reading at greater than 50%. But at greater than 1%, we actually start to lose our concordance. It goes down to as low as 0.53. And this might be also partly explaining why we do so poorly with immune cells, because we're trying to tell the difference between 0 and 1% or 1% and 10%, which are more subtle than telling the difference between 50% or less than 50%. So in another study, we actually looked at this quantitatively. And looking at this quantitatively, we could actually look at each of the antibodies, not the assays. What I just showed you was looking at the assays, but this study looked at the antibodies, and we took each antibody and determined its maximal signal to noise. And so in fact, when we determine the maximal signal to noise, we can look at the actual concentration of the antibody, not the dilution, and figure out what the positive cases are, what the negative cases are, and then do a ratio and figure out the signal to noise. And when we do that using an array like we're showing you over here, we can actually compare the antibodies to each other to see if what we saw in the assays was an artifact of the way the assays were constructed. And in fact, that may have been the case, that one way to think about it is the antibodies are the eggs and the assays are the cake. And so the cakes might be very different even if the eggs that you start with are all equivalent. And in fact, that's the case. This SP142 antibody, even though the assay was by far an outlier, looks essentially identical when you use it at an optimal signal to noise. This is another example of a higher power view where we used SP142 antibody at an optimal signal to noise, and you can see it looks essentially no different from the other assays that were generated. So we compared all 6 of these antibodies in the study, and what we found, they're all essentially identical. And so across about 25 different cases, and then looking at regressions, you can see that the antibodies all agree with each other themselves. So that's the good news. The good news is the antibodies are the same. The bad news is some of the assays are constructed in a way that makes some of the assays, or at least one of the assays, quite a bit lower. So the antibodies are similar, the assays are not. The Ventana SP142 assay, as prepared, detects only about 1/2 of the signal compared to the other 4 assays, as confirmed by 2 of the multi-institutional studies. The quantitative studies suggest the immune cell PD-L1 expression correlates with tumor cell expression. I actually didn't show that data, but studies comparing the pathologist scoring of the immune cells suggest that the concordance is poor, while pathologist scoring of tumor cells is great, in fact, better when we use the highest cut point, greater than 50%. So with that, I want to talk about some of the novel biomarkers and then some of the future biomarkers. So one of the novel biomarkers that was discovered early on by Dr. Rizvi and his group was the mutational load. The fact that you could see patients with higher mutational load were more likely to respond to therapy than patients with lower mutational load. This was the discovery cohort, the validation cohort, and then combined. And this makes sense since it's the mutations and the increasing number of mutations that ultimately leads to generation of neoantigens, which theoretically stimulates the immune system. Another example of this is shown in mismatch repair deficiency, where mismatch repair proficient colon cancers don't generate so many neoantigens, but mismatch repair deficient colon cancers have very high levels of mutational rates, and maybe an order of magnitude higher, and these are the patients that actually do very well, as shown in this work by Lee et al. So does this follow all the way to neoantigens? Yes. In fact, if you look at neoantigen load, instead of mutational load, the same thing is seen, where high levels of neoantigens in colon cancer and melanoma and non-small cell have all borne out to be more likely to be associated with response to therapy. This is further validated more recently in some larger studies where, again, you can see that the high mutational load or high number of mutations per megabase are more commonly seen in responders, and overall they do better. So should we switch to this? Should we abandon the PD-L1 assay and just measure mutational load? The problem is the sensitivity issue. And the sensitivity of these assays tends to be between about 50 and 70%. And an assay that we use in the clinic, we don't want to have that many patients miss the opportunity to benefit from the therapy. So we're looking for assays that are close to 90%. The PD-L1 IHC assay is not that high, but it's closer to 90, it's closer to 80% than the 60% that we see with mutational load. So what about other biomarkers or other sort of future things could we think about? And is there hope for getting higher sensitivity or maintaining that high sensitivity, but also bringing up the specificity? So I want to talk about a couple of theoretical things that use some new boxes that might need to be introduced into our labs. One is the PerkinElmer vector platform and the nanostring platform. And both of them have been used toward the goal of coming up with a more complex question than just, is it positive or negative? The first was based on the observation that patients that are responders have a lot of T cells. In fact, the higher the so-called, as you saw before, the patients that have a lot of immune infiltrate as opposed to the immune desert patients do much better, and that's what's shown here. They also similarly have high PD-L1. And so we've come up with an assay where we try to look at a combination of tumor-infiltrating lymphocytes and PD-L1 and combine them into 3 types. The ones that are the immune desert, those need some combination therapy to bring the immune cells in. But what about the ones that have immune cells present? It would be good to be able to subclassify those into the responders and the non-responders. And the way we've tried to do that is take the positive ones and put them into one of 2 classes. Type 3, which are the activated T cells, they have high granzyme and or high Ki67, or type 2, the ones that have high CD3, lots of cells there, but low granzyme and low Ki67, presumably those are inhibited by something. Well, when we look at that in a relatively small pilot population study, we can see that in fact CD3 bears out, and there are more high CD3s in the responders than the non-responders, but by itself, neither granzyme nor Ki67 is actually predictive of response. But when we combine them all together with that algorithm, that is to combine them into 3 types that are activated or inactivated, we see something very interesting, and that is that in this population, although there's only 7 type 2s, none of them have died of the disease at this point. And the progression-free survival is also statistically significantly better than the type 1s and the type 3s. Now, the type 2s, remember, are the ones that have a lot of T cells, but don't have granzyme or Ki67 in those T cells. So those are the ones that are dormant. Perhaps they're checked by a checkpoint. which may be what we're inhibiting and why we're seeing response to therapy. So a potential way to bring an assay on that isn't based on the tumor cells themselves, but actually based on the immune microenvironment that we might see in the future as a mechanism to predict response to PD-L1 axis therapies. So this is still really preliminary data, but I'm just sharing that Stand Up to Cancer cohort is underway, and that this is even a smaller study with only 37 patients is not statistically significant, but it gives me increased confidence. This is why I share it with you. It's a different disease, it's melanoma, and not only is it a different disease, but it's a different platform. This was done with a different software to try to distinguish the type 1 versus type 2 and 3. And in fact, you can see the type 2 group once again does better than the type 1 and type 3. And hopefully in 3 to 6 months, we'll have much more data on this potential test. Next one is the capacity to express PD-L1. So maybe the reason that we see some of those cases that are PD-L1 negative that respond to therapy is because we're not looking in the right place. So PD-L1 down here is activated by a promoter IRF1 and NF-kappa B, depending on which pathway you go down to actually stimulate PD-L1. And so perhaps you have to see the microenvironment right at the right time. But we pathologists, we don't get to choose the time. The tissue comes when the tissue comes. And so maybe we could look at potential or capacity to express PD-L1 instead of PD-L1 itself. And that's what this study was based on, focusing first on IRF1 and later on NF-kappa B. And what you can see in patients who have high IRF1 do better in terms of response to therapy than patients with low IRF1 compared to PD-L1 in this relatively small melanoma cohort. But as you can see, again, here in about 70 patients, the patients with high IRF1 have a longer disease-free survival than those who have low IRF1, even though in this melanoma cohort, and as has been seen in many melanoma cohorts, PD-L1 by itself doesn't classify the patients for outcome. So another approach that we hope will ultimately be promising, and it's easier to read. It's a nuclear expression, and here's even an example of a case where you can see pretty strong nuclear expression of IRF1. This is not how we did this study. This is just a parallel DAB assay simulating what would be done in a pathologist lab, where you can see that even though it's IRF1 positive, it's negative for PD-L1 in a serial section in the exact same region of the tumor. So the last thing I want to talk about in the last minute or so is the nanostring 18 gene assay. And this is the idea behind this, is that you could actually grind up the specimen and look at the immune signature of the assay. Now, as much as I like doing things in situ, I think sometimes you can do much higher degrees of multiplexing. And in fact, that's what nanostring did. They looked at many of these different markers that regulate and modulate the CD8 positive T cells and other T cells that may have interactions. And in fact, RNAs from the tumor cells as well. Ultimately, starting with close to 800 different genes, they looked at a bunch of cases and then looked at ROC curves and decided these were the most selective genes. Some from the interferon gamma pathway, some from the T cell exhaustion pathway, and some from pathways that sort of made sense, but it wasn't clear what role they had. But empirically, these were the ones that they found were likely to be most predictive. And I'm not showing the whole data set, but rather I'll just show the area under the curve compared to PD-L1 using their 18 gene classifier score is this area under the curve on top, which actually looks quite promising compared to the PD-L1 assay. And this is actually in squamous cell cancer of the head and neck, but has been seen in other assays as well. So this is something in the future. We know from press releases that good progress is being made toward testing this even in the prospective setting and some retrospective work on some of the keynote and checkmate studies. And we look forward to seeing the results of these kinds of assays, which might be another future approach to pick the right patients for the right therapy. Thank you.
So I'm going to really go through a few scenarios of how immunotherapy could be used in everyday practice. It's not meant to be an exhaustive overview of how I use immunotherapy in practice, but I think this is a good case that's illustrative of some of the topics I'd like to cover. This is a patient with a KRAS mutant lung cancer who received single-agent PD-L1 therapy, had a complete response after just 6 weeks of therapy. And after about a year of therapy, she developed fairly significant skin toxicity, a fasciitis that was quite symptomatic for her, requiring her to come off trial. And now she's been off therapy for over 2 years, and her PET scan looks really identical to the one on the right. So I think it begs the questions such as, how long we continue these therapies, what do we do about toxicities, how do we manage toxicity? So the questions I'm really going to try to address are the duration of treatment. If you have a patient receiving immune checkpoint inhibitor therapy and they have a complete response, do we stop treatment? If patients have a toxicity to a therapy, is that a reason to stop treatment? And how do they do in terms of outcomes if patients have toxicities or no toxicities? And the standard treatment for patients who have an immune AE is steroids, which are immunosuppressive. And I think everyone gets a little bit worried about whether that abrogates efficacy of these therapies. The other topic I'd like to touch upon is really what we see in the clinic, where we don't see a beautiful PET response like I showed you in every patient. And it's in the clinic we do see scenarios where some areas of tumor respond, other areas don't, other areas progress. And what do we do about those situations? And finally, what do we do about patients who do respond and then ultimately have progression? And the last topic is patients that are older or have poor performance status. Certainly the poor patients weren't included in most clinical trials, and how do they do with immunotherapy? So the first topic is complete response or reason to stop treatment. I think that we're seeing this more and more with immunotherapy, where we are seeing complete responses. For example, in the lung experience with first-line pembrolizumab in PD-L1 positive disease, the complete response rate with pembrolizumab was nearly 10%. The melanoma doctors experience complete responses with their therapies even more frequently. And what do we do with those patients? So the short answer is we don't have a lot of data. There is some data from the melanoma experience and the KEYNOTE-001 trial where patients had a complete response. The data looked at and what happened to them. And keep in mind for this trial, if you have a complete response in the melanoma patients, you're actually allowed to come off trial if you have a complete response that's maintained for more than 6 months. So the criteria from this trial was 6 months CR, ongoing, you can stop therapy. And so in fact, of these 95 patients, or 15% of melanoma patients that had a CR, 64% stopped for observation. There were 17% that were discontinued actually due to AEs, and very few patients discontinued due to disease progression, and the 19% at the time of this presentation remained on pembrolizumab. And there's a lot of data here, but I think it's really pretty compelling. What's most compelling is that if you have a complete response with melanoma, 97% of these responses were maintained. The median time on treatment was nearly 2 years, and off treatment was about 10 months. And these complete responses don't occur overnight. If you look at the blue circles, that's the time to partial response, and then the dark blue circles are time to complete response. So the median time to CR was actually 13 months. And as mentioned, 97% of these responses were maintained. So I think there's some data, certainly from this experience in melanoma, where you have a CR, they maintain a CR for 6 months, one can say with some certainty that their benefit is fairly durable. What about toxicity? Is that a reason to stop treatment, and do steroids abrogate efficacy? Again, we're starting to see more and more data. This was a publication from MSK with ipilimumab in melanoma. It was patients that were treated off protocol. About 300 patients were treated. 19% of patients discontinued ipilimumab due to toxicity. 35% required steroid use, and 10% actually required anti-TNF use. And you can see on the left two panels, with no toxicity or with any toxicity, there was really no difference in terms of outcome. And similarly on the right, whether they received steroids or did not receive steroids, the outcomes were very comparable. Actually, in 12% of these patients, long-term benefit was experienced even off therapy. So one of the kind of reflex of doctors, maybe if you have a toxicity, well, if you can't go back to the immunotherapy for a bad toxicity, you go on some other treatment. And I think that may not be true. I think observation is very appropriate. My most extreme example is a lung cancer patient who had PD-1 therapy and after one dose developed type 1 diabetes with a glucose of 600 and renal failure. And he actually had nearly a CR from that one dose of PD-1, and now he's out about 9 months with that CR being maintained, and he actually had osseous metastases as well. So the additional data with nivolumab, again in melanoma, this was 4 BMS trials that were looking at nivolumab monotherapy with immune modulation or without immune modulation. And if you look at the response rates, the PR rate is in the mid-20s for both, and the duration of response is again fairly comparable. Immune modulatory use was in about 35% of patients, and 25% did require steroids. So whether you got steroids or not, the outcome seemed very comparable. Finally, in terms of combination immunotherapy, where we do see more immune adverse events, with Nivo and Ipi and melanoma, you can see in the left panels that the number of patients from all randomized on this analysis, 40% received more than 4 doses of Nivo, whereas 23% received more than 4 doses of Nivo if they discontinued due to AEs. So 35 out of the 94, 35 patients discontinued due to AEs, whereas 94 were randomized. And on the panels, you can see not just the overall response rate, but also the complete response rates. Those deep responses were really quite comparable, whether they had a toxicity or not. And this shows the PFS for whether patients discontinued due to AEs or no AEs in the top 2 curves. The bottom curve was with Ipi alone, which is what you'd expect. What about tumor heterogeneity or mixed response? This is a patient that I'm treating currently with PD-1 therapy. You can see she has fairly bulky lymph nodes in her mediastinum, and after 6 weeks of treatment, you can see clear response to her lymph nodes. She actually couldn't turn her neck due to extensive cervical and supraclavicular lymph nodes as well, which totally resolved. But on that same scan, she had a right lower lobe mass that seemed to increase and causing collapse of lung. Her nodal disease obviously was responding though. So what do you do for a patient like this? Well, for this case, we actually continued the immunotherapy, but irradiated her lung primary. She re-expanded that lung, and on follow-up scans that we did a few months after the radiation, she continues to respond to her nodal disease, and she's having an ongoing response. And so isolated progression does not equal treatment failure, and I think that's important to note. And local areas of progression can be managed with local therapy, and the immunotherapy can be continued. And part of the reason may be that all the different areas of cancer may not represent the same disease. David showed our data around pembrolizumab-treated patients having a correlation of response based on mutational load. So the more non-synonymous mutations you have, the more immunogenic a tumor that exists, and there is that correlation. But I think that we scratched our heads around some of the data that we had, where in the arrows you can see there are 3 patients who had high mutation burden, but those were non-responders to immunotherapy. So the patients on the left of the middle are the responders, and the patients on the right were the non-responders. And those 3 patients actually had a significant subclone fraction. They were fairly heterogeneous tumors, and so despite having a high mutation burden, they were heterogeneous in nature and ultimately had treatment failure. So I think that one needs to factor tumor heterogeneity in terms of clinical application. Acquired resistance, what do we do about acquired resistance? Again, we're seeing that more and more. Data from Tony Rebus's group in UCLA has begun to study this more systematically. And in these melanoma cases, there are very specific alterations that have been detected around cases where acquired resistance has developed, loss of function JAK mutations, loss of function beta-2 microglobulin mutations have been increasingly being described in the scenario of acquired resistance. And I think going forward, as we understand this biology, we'll be able to develop ways to overcome these mechanisms of resistance. We see this in non-small cell lung cancer as well. This is a patient of mine who in the first panel was pre-treatment, and then the second panel was post-treatment, showing a treatment response, and then 15 months later developed an isolated nodal area of progression. We actually resected that node, and again, as we discussed earlier, we should manage patients who have local areas of progression with local therapy, and he remains off of therapy with an ongoing complete response about 18 months after that nodal resection. We too analyzed that lymph node to look for a smoking gun in terms of mechanisms of resistance, in terms of upregulation of PD-1 or TIM or LAG, development of resistance mutations such as beta-2M or JAK and other mutations, but we really found no smoking gun in this case. And I think the challenge for understanding resistance to immunotherapy is it's not going to be as straightforward as EGFR mutant lung cancer, where you develop a T790M mutation. I think that the resistance mechanism is going to be very diverse in nature, and I think will be part of the challenge. Can we rescue patients, right? That's the question that comes up every day, which is why our phase 1 clinics are very busy with immunotherapy combinations. So if you treat a second-line lung patient with single-agent PD-1 and the response rate is 20% and the durable response rate is 10%, well, you're clearly not helping most of the patients. And what do you do after that? Is there an opportunity to rescue those patients? And the short answer is we don't know. This was an interesting case that I've been treating, though. It was actually an MSI-high colorectal cancer patient who had progression of disease after standard chemotherapy and was treated on a protocol with us with single-agent PD-L1. He received 14 cycles of treatment. He actually had a minor response. He had a big presacral mass. He had improvement in his pain and neuropathic symptoms, but then did progress with escalation of his pain and neuropathy. And we, at that point, we rebiopsied him and we started him on a combination of PD-1 and CTLA-4. And you can see on these images that his presacral mass going from August to December has clearly decreased in size in both views, and he has essentially resolution of pain and resolution of neuropathic symptoms, and is continuing on PD-1 and CTLA-4 combination therapy. So I think there is an opportunity to rescue patients, but I think we need to biopsy these patients and try to test them on protocol when we can to inform combination strategies. Finally, age and performance status. As certainly for performance status, as you know, most patients were limited to ECOG 0 to 1 performance status for many of our clinical trials. The other exclusion criteria was autoimmune disease. I didn't put up a slide for that, but what we see now clinically is patients, in the real world have autoimmune conditions, and what do you do for patients that come in with a history of Crohn's disease or rheumatoid arthritis? And I think that in general, what we've been doing is sort of weighing the pros and cons for immunotherapy. In general, we do see flares of toxicities in terms of psoriasis, which is clearly manageable. We get more nervous around patients who have active ulcerative colitis or Crohn's disease because then those can flare. But I've had a patient with active MS who we've treated who didn't flare. So I think it's a bit of a learning curve, and we're seeing more and more data emerging around treating patients with a pre-existing autoimmune condition. So we do have some data from the bladder experience around poorer performance status or patients with comorbidities. The atezolizumab trial looking at patients that were cisplatin ineligible. They could be ineligible for either renal impairment, history of grade 2 hearing loss or peripheral neuropathy or ECOG PS2. In this cohort, there was a little over 100 patients that were treated with atezolizumab. And if you can see by the baseline characteristics, the overall population, the response was in the mid-20s. Even for the older patients, the response rate was 28% and more than 80 years of age. And as you go down, if you look at the impaired renal function, ECOG PS2, and even renal impairment in ECOG PS2, the response rate remained in the mid-20s. So suggesting that even in those patients who are more compromised, activity is seen with PD-1, PD-L1 therapy. A similar patient population was studied with pembrolizumab, and this was in patients, again, who were ineligible for cisplatin based on renal failure, performance status, neuropathy, hearing loss, and in this case, CHF as well. And in these patients, the characteristics are shown on the left, and prior treatments are shown on the right. And you can see in terms of the response rates, with the PS2 patients, the response rate was a little lower than what we saw with the atezolizumab, but clearly was still very active. One of the interesting observations in this trial is of the patients who had visceral disease or hepatic metastases, those tumor types seem to respond less well to immunotherapy. So visceral disease, hepatic metastases, the response rates are clearly lower, and that's really across tumor types that we're seeing that observation. But PS2, I think, is not a preclusive to IO therapy or elderly patients. So to summarize, the duration of treatment for these therapies is not yet defined. It's open-ended and indefinite for the majority of clinical trials and approvals. There are some trials which are capping at 2 years. I think that one can say in terms of duration of therapy is those patients, who have a complete response, certainly in the melanoma experience, it's not unreasonable to stop them if they've had a CR that's been maintained for 6 months. Immune AEs do not preclude benefit if they're given corticosteroids. So I think for the people in the practice, don't be afraid to use corticosteroids if you need to treat their immune adverse event. Mixed responses can be seen in practice and may not represent systemic failures. I think that if it's for patients receiving PD-1 therapy and they progress in every lesion, then I think that that's a different scenario. But isolated areas of progression should be managed with local therapy. Multiple mechanisms of acquired resistance can occur with PD-1 therapy. We potentially have the benefit to overcome that with combinations as we go forward. And finally, PS2 patients do benefit from IO. And I will stop there. Thank you. We are now during our question and answer period. Feel free to come up to the microphone. We're not bad time-wise. We were allowed to go a little bit over 9. And I will read the questions here. We have a few here already. And I think that the first one is, I think everyone can weigh in the group. David can start with this one, probably. Is there really any purpose in measuring the levels of PD-1, PD-L1, whether they are low or high, if PD-1 inhibitor therapy is used irrespective? Dr. Rim's presentation shows that their assays seem to be meaningful, but how does it matter clinically?
Well, the question clinically maybe you should address, but how does it matter? I mean, it does matter, and we certainly see responders. And I think more than even to pick, if it's a complementary diagnostic test, obviously you don't have to do it. If you want to use it in the first line in lung cancer, you do have to do it, and the patient has to be greater than 50% to be on label. But I think even more important than that is that when you see a patient that's completely negative, that's a good patient to try and put on a clinical trial, as opposed to think about just giving them Nivo or something like that.
Jeff, do you do it in melanoma?
Would mirror what was just said by David Rim. In melanoma, we really aren't doing a lot of biomarkers to select patients up front. It's more for research purposes at this point.
So I mean, some of your data in melanoma suggests that if you're PD-L1 positive, Ipi-Nivo performs comparably to Nivo, whereas if you're negative, the Ipi-Nivo does better. So to spare toxicity, would you do a PD-L1 test in melanoma?
So that's been brought up a few times, and the data that we currently have, I think, is still very controversial, though we may get more data soon.
Survival data coming up, right?
Exactly. So, but I think it all depends on how you want to look at it. The original presentation by Jed Walchuk, basically if you're PD-L1 positive, the PFS curves overlapped if you got nivolumab or nivolumab plus ipilimumab. And people use that as an argument that you really shouldn't give people the added risk of toxicity with the combo if you're going to end up at the same place. But that was despite a higher objective response rate in that same comparison. So you kind of had to ignore that part of it. The second time it was presented, it did look like there was a separation in the PFS between the two groups that were PD-L1 positive treated with Nivo-Ipi versus Nivo alone. So I think it's really still unknown based on the data that we have. I personally haven't used PD-L1 testing to decide between Nivo or Nivo plus Ipi in my patient population, but I'm sure there are people out there that have.
Eddie, would you offer immunotherapy to a non-small cell lung cancer patient who is a fast progressor?
Excuse me. Yeah. So interestingly, so there are two things on that. One, there is data emerging that if there really is a fear that the patient is progressing too quickly, that one could use combinations of chemotherapy and immunotherapy. Those are not currently approved therapies, but there is some data supportive of that. Interestingly, in the patients who do respond, when we initially were conducting these studies, our concern was that it would take months for these patients to respond. And clinically, that isn't necessarily what we have seen. We have generally not seen people who are the responders, or who, for instance, the patients who were frontline who had high standing for PD-L1 did quite well, even if they were, presumably some of those people were progressing and did have very high disease burden. So yes, I would be willing to do that if their biomarkers otherwise were suggestive. And that is, I think, an excellent example where having that biomarker data might make one feel quite different about it.
Right, so from Keynote-24 lung experience, if you are PD-L1 positive, the response rate is numerically higher than with Pembro than with chemotherapy, and also the time to response is really identical. So you're not going to, lose out in terms of rapidity of response with IO versus chemo. Do you have some questions there?
We were given additional questions.
We have a bunch of questions. I can do one really quickly. Do you foresee flow cytometry to play a role in future companion diagnostic assays? And I would say the answer to that is probably not. So far, there's really not been much signal in peripheral blood, at least at a cellular level, and taking the tumors and dissociating them for flow cytometry analysis has historically not worked, because in order to dissociate them, you cut off the interesting molecules that you want to measure. So I would say I wouldn't bet on that technology.
Sure. There was a question that I think was geared towards maybe the talk that I gave. Are preclinical data in vivo predictive of human clinical trial IO inhibitor combination results? That's a very tough one to answer. Obviously, we've seen combinations in vivo that probably don't play out in clinical trials, but then, of course, most of our successful clinical trials had positive preclinical in vivo data. So I don't think it's a guarantee if you have a positive animal model showing IO therapy is necessarily going to play out in a clinical trial, but it's the starting place. We also struggle with what is the best in vivo model. So melanoma B16 has been used over and over again, and people heavily criticize it, yet it's still used again. And there are now GEM models that might be a little bit better, like Marcus Bosenberg's model, although that may not quite replicate what we're seeing in humans. So the biology of that melanoma may be slightly different. So I think it's something that we still struggle with a lot.
So could you speak to how response correlates with immune toxicity? And this is a somewhat controversial area, and I will say that Aaron Lisberg from our group, who will be joining our faculty, has a paper out for review on this topic. Jeff Weber does have an article in JCO which indicated a correlation. I would say that in general, it is very easy to show a correlation between response and immune toxicity, but that is heavily confounded by the idea that people who are on therapy longer are more likely to experience toxicities. So I think that there is some suggestion that that may be true, but it is controversial. And when we look at our data from the Keynote-001 study, patients, we had nearly 100 patients at our institution. We think that it is suggestive of that when we remove the sort of caveats, but I think it is a hard question to study.
Can I ask a second question on top of your question? So is the toxicity more of a dose-finding experiment, meaning that you basically proved in that patient you've revved up the immune system and you achieved what you're trying to do? Unfortunately, the patient had toxicity, but hopefully will have benefit.
Yeah.
So as a follow-on to that, there was a question was whether steroids can be given prophylactically to prevent development of AEs, and I think that is something that we don't want people to do. I think that that most patients don't have immune AEs, and we actually don't know whether it's detrimental to give somebody prophylactic corticosteroids. We know that if you develop a toxicity, they seem to do okay if you give them steroids, but to rotely give it prophylactically, that actually could be a negative effect and wouldn't be something that we'd recommend. Have you tried comparing?
Now we have someone.
Oh, I'm sorry.
Brave enough to go to the microphone.
I have a two-part question, actually, and maybe a little bit too basic. But the first question is, have PD-1 and PD-L1 been documented in the tumor and the tumor infiltrating lymphocytes in biopsy specimens? And the second question is, has anyone studied the immune repertoire of the tumor infiltrating lymphocytes in treated patients?
So PD-L1 and PD-1 clearly are present in, the PD-L1 is clearly present in tumor cells. PD-L1 is present in some immune cells. It's been shown that they're present in macrophages and some T cells. And PD-1 is a much harder marker to use since it's expressed in a lot of cells. There's a couple of studies that have looked at I think what you're asking, the co-localization of PD-1 and PD-L1 in the same cell or interaction. Yeah. And there was one study presented last year at AACR where the interaction, that is the co-localization, was more predictive than either molecule by itself. We'll wait and see if we get confirming data on that concept later this year.
Sorry, I probably asked the question wrongly, but do the antibodies, have they actually been documented to penetrate into the tumor and coat the surfaces of the respective cells?
The therapeutic antibodies?
Yes.
Not to my knowledge.
Uh-huh.
Did you want to talk about the T cell repertoire? That's the second question. Which was, you want to repeat the second question?
Yes. Has anyone studied the immunoglobulin the T cell receptor gene rearrangements in the tumor infiltrating lymphocytes, and can we gain any insight from those rearrangements? Yeah,
so arguably that's a potential prognostic factor that I omitted in my genomics part of this. And there's a company called Adaptive, and there are a number of other competitors in this space where people are looking at the T cell receptor repertoire, and with the hope that they would either find a specific clonal alteration that would lead them to a prediction of a therapeutic response. Data on that is, I think, still forthcoming.
Thank you.
Okay, Eddie, are PD-1 and PD-L1 treatments overlapping / interchangeable? Would you use an anti-PD-L1 in a patient who failed anti-PD-1?
So I would say this question is one that I get asked by colleagues very frequently. I would say that my bias is that I think that it is unlikely that someone will respond to one when they have progressed on the other, although I would also say we don't have definitive evidence, and I think that we're getting that empirically because some of those people are doing it. No one has ever called me after I've told them that I would find it unlikely that they would do well to tell me that the patient did great, but that doesn't rule it out.
Okay, a couple more. Jeff, can you discuss pros and cons of intratumoral drug delivery versus IV drug delivery? How problematic is it to give Tvex or some of the newer agents that are entering the clinic, such as STING agonists? I mean, how tough is it to give it? Can you give it, through IR and start injecting liver lesions and everything else?
So the easy answer is yes, but it does pose new challenges. So you need to have a patient that has injectable lesions, and injectable could be sort of in the eye of the beholder. We're normally talking about in melanoma, someone who has dermal metastases, either in transit or distant. Those are the ideal patients that in the clinic could be injected. But in theory, it can be done in interventional radiology, and certainly people are thinking about that at the moment. Some of the nuances, though, can vary whether you're talking about an oncolytic virus versus a compound or an antibody. For example, Tvex does require special handling. It requires special preparation in the pharmacy. So it's not like you could see a non-small cell lung cancer patient who's getting Pemble, and the next person that comes in, you're going to set up and treat them with Tvex and then flop back and forth. So there's a lot of logistical issues with that. For the injectable lesions, I would say the surgical oncologists have played a major role in administering that treatment. Certainly med-oncs are doing it, but I think the surg-oncs have been more integrated. And then obviously the IV antibody therapy we've dominated in our clinic. So I think that may be a feasibility issue in certain clinics, certain patient populations. So that might also play a role in how we utilize the treatments.
Okay, thank you for coming out. Thank you to the speakers.
Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerreviewpress.com/MWM. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. This activity is supported by educational grants from Genentech, Insight Corporation, and Merck & Company Incorporated.